I'm going to present on the behalf of Medicine 4. My topic is ATP. Should you identify the spotter? Anyone? Not Escar.
Sorry, what does it say?
Escar.
Escar, okay.
Not Escar. Erythema multiforme. I'm going to explain about the condition.
This is the thigh, yeah? This is the thigh?
Yes, sir.
Thigh.
At the end of the session, I'm going to discuss about the erythema multiforme. 56-year-old gentleman, Mr. A, labor from Vellore. He presented with the complaints of fever for 6 days and skin lesions for 6 days and oral lesions for also for 6 days. The skin lesions are also you saw in the previous picture. That was like skin lesions all over the for the past 6 days. Multiple discrete fluid-filled lesions surrounded by erythema in the upper limb and lower limb and trunk and abdomen. And fever also was high grade, intermittent, not associated with chills and dry hair. And oral lesions also for the past 6 days, sudden in onset, gradually progressive, involving buccal mucosa, has bloody incrustation associated with the drooling of saliva. He has no history of cough with expectoration, cold, nasal stuffiness, or seasonal variation. No history of cough with expectoration on the evening receive temperature, night sweats, loss of weight or loss of appetite. No history of photosensitivity, Raynaud's phenomenon, swelling and tenderness of joints or rash. And he's a diabetes for past 6 years and hypertensive for also for past 3 years. He's on regular medications also for the last 1 month. And the vital signs, we was presented the BP 120/80 and pulse rate was 90 beats per minute, saturation was 97, respirated was 20 cycles per minute. And he was presented with the pallor and the pedal edema was also was present. No cyanosis, no glubbing, no icteric, no generalized lymphadenopathy. And the skin involvement, the skin lesion, there is a lower lip erosion with the crust measuring 4 into 2 centimeter in size. Few vesicular lesions with the surrounding erythema with the central clearing noted in the abdomen and upper back and upper and lower limbs. On CVS system examination, CVS and RS examination, there is no significant findings. And lower abdomen also soft, no tenderness, no arachnomegaly, normal bowel systems here. And central nervous system, no focal neurological deficit. And upon initial evaluation, CBC showed there is a anemia with leukopenia with the thrombocytopenia, and the reticulocyte count was 0.09, and ureter was bland, and LFT it shows elevated level of bilirubin level, AST, ALT, and the transaminase level are normal. Renal function creatinine was elevated, and BBVS also was negative, and blood culture shows it has no growth. On the skin lesion, we did a biopsy. It shows focal epidermal necrosis and epidermal dysmaturation and the features of acute folliculitis. And with the inconclusive of, we went to that bone marrow. A bone marrow biopsy shows mildly hypocellular marrow with a decrease in mature myeloids and megakaryocytes. The syndrome complex of oral lesions involving the mucous membrane and erythema multiforme of skin lesions and pancytopenia. Our differential diagnosis will be infectious mononucleosis, parvovirus, viral hepatitis, acute HIV infection, herpes simplex virus, cytomegalovirus, oxyvirus, or drug induced. With that, we found out until otherwise, we did not find out the cause. And again, we went back to the medication history with the diabetic and hypertensive. There was one drug was there, the tablet methotrexate 2.5 mg AMOD. He was taken 8 tablets for the last 2 weeks. It was given by as a dispensing error from the pharmacy. Instead of Mevil, they have written as a methylcobalamin. They are given as a Mexit 2.5 mg for the 1 month. But he took only for the last 2 weeks for 8 tablets. So it causes a methotrexate that causes a myelodepression and also for the pancytopenia and oral mucosal lesions also for the erythema multiforme. Erythema multiforme is the acute immune mediated eruptions characterized by distinctive target-like skin lesion with a tend to affect distal extremities. Causes was herpes simplex was the most common cause, and mycoplasma pneumoniae, parvovirus, adenovirus, Epstein-Barr virus, cytomegalovirus, and HIV infection, mycobacterium tuberculosis, histoplasmosis, drugs, NSAIDs, sulfonamides, anti-epileptic medication, and antibiotics. The exact mechanism of the erythema multiforme we didn't know. Mechanism we didn't know, but there is a theory was suggested there is a herpes associated in phenomenon. Normally, the DNA virus was engulfed by mononuclear cells. In this herpes simplex virus, it exhibits a cutaneous lymphocyte antigen, which engulfed by the mononuclear cell, which present the antigen to the keratinocyte and the epidermal layer. In that, the viral DNA were fragmented. So the fragmented viral DNA it causes a cell-mediated immune response that causes a erythema multiforme like lesions. The cutaneous involvement was target lesions are the hallmark of the disorder. It is most likely present to be the central necrosis also was there, but there is a clear area. Initially, round erythematous papule evolves into classic target lesions. Symmetrical distribution on the extensor surface of the acral extremities and spread of a centripetal manner. Mucosal involvement was oral, ocular, and genital mucosa. It manifests as a mucosal erythema and painful erosion and bullae. And systemic, the fever, malaise, and myalgia, and erythema multiforme related infection etiology. What was the patient have the primary infection that were related to the systemic feature will be present in the patients. For our patient, we did a methotrexate level. Methotrexate level shows elevated level. Normally, the target level was the patient undergoing the under the methotrexate treatment was 0.001 millimole per liter. But our patient has elevated levels of methotrexate. So he was treated with the fulinic acid 22.5 mg. The dosage of fulinic acid was 10 mg per meter square. So after that, the patient saw our patient saw responsive to medications also. At the time of discharge, hemoglobin was 10.4. Reticulocytes are also elevated. Platelet count was 1,81,000. Total leukocyte count also 8,600. So learning points. In our case, there is a complete medication history was available with the diabetes and hypertensive medication only he was taking care of until we know. After that, getting from the last hospital prescription also we found out to be that there was a one drug instead of vitamin multivitamins the pharmacy they have given as a Mexate 2.5 mg. It was an outside hospital. Thank you.
Thanks. So this patient, the lesions are resolved?
Yes, sir. Lesions are resolved.
Any comments?
Just one time. When you give folic acid, do you water methotrexate levels? And so, how often do you water?
Methotrexate will that 2 months after it will be not it will be showing like the same level of this. We have 2 months, sir.
Up to 2 months after you stopped and given the fulinic acid, be raised for 2 months.
Sir, we have found out to be the elevated level only. After giving the fulinic acid, it won't decrease the methotrexate level as soon as immediately.
So immediately take some time.
Yes, sir.
So by daily counts.
Sir, daily counts we have monitored. So there is a significant improvement also, sir, day by day.
When you decide you take stop folic acid or you decide to stop folic acid?
Folic acid based upon the immune response also was there, sir. With that only we stopped because without Rexit we can't able to assess.
Counts pick up, so you stop.
And also the patient also symptomatically was relieved.
How long you give for this patient?
For 7 days we are given, sir. For 7 days.
7 days.
7 days.
And get fever also in this patient.
Yes, sir. Fever.
Right,
Also. Fever was also cyanide bacterial infection we thought of, sir.
You gave him you gave him antibiotics as
Antibiotics,
well? And atypical cover also you gave?
Atypical clindamycin also we gave.
But
meropenem he was also on and clindamycin, sir.
For that skin lesion. So you thought of staphylococcal and give clindamycin.
And methotrexate with the erythema multiforme is common.
There is some.
Was it just native? Like a native which caused
said that most commonly the drug-induced reaction will be the erythema multiforme. So with the history in lesions, we have found out to be that there is a associated any other sanitary infection was we found out to be. After that, dermatologists and our team also was involved. They have found out to be the lesions are majorly due to the erythema multiforme. In our patient, there is no systemic infection. The BBVs also we have done, and all other lesions.
But culture also is negative.
Also is negative, sir. So we have found out to be the drug-induced maybe that we thought of, and also we send out the methotrexate. It also gave us a elevated level.
Because yeah. I guess it's possible. Yeah, the leukopenia is well explained, but the skin lesions, how common are the skin lesions with methotrexate?
So there is a
You don't have the, like, how often does it happen? This
so in our patients skin lesions normally the acute toxicity there will not be skin lesions, sir.
mainly we found mainly oral toxicity and
Oral
diarrhea and
lesions.
leukopenias.
The chronic toxicity only showing some articles of skin
lesions. But this patient was taking last 2 weeks only.
Last 2 weeks.
2 weeks. He was taking daily methotrexate.
Yes, last 5 days was daily. Sir.
Daily.
You know, previously was in between infrequently he was taking.
When the bone marrow report was normal?
Bone
marrow?
Bone marrow it shows
normal.
hypoplasia. Sir.
Hypoplasia.
Yes, sir.
Okay.
Erythroid mycorrhizal.
Thanks. Next we'll have